Good afternoon. We are going to today discuss about the cardiomyopathies. This is not an ordinary presentation. This is the state-of-the-art presentation of what you all need to know about the cardiomyopathies, the diagnosis, the genetics, and we have the latest guidelines of European Society of Cardiology and American Heart Association 2023 and 24 respectively. These guidelines are translated into clinical practice in this presentation. Define the 5 crore morphological phenotypes, including the new NDLVC classification. You may not even be knowing what is NDLVC. Apply the integrated cardiomyopathy mindset to the clinical workflows. Navigate the multimodality imaging and genetic testing pathways for etiological diagnosis. Now, what are the structural phenotypes of cardiomyopathy? That you need to understand, right? Defining the structural phenotypes. HCM, hypertrophic cardiomyopathy. Earlier it was called HOCM. Use the current terminology, HCM, hypertrophic cardiomyopathy, where you can see the septum is hypertrophic. Unexplained left ventricular hypertrophy, particularly the septum and the left ventricular wall are very much thickened. DCM, dilated cardiomyopathy. Left ventricular dilatation will be seen and systolic dysfunction is the hallmark. NDLVC, non-dilated left ventricle, a new entity. The left ventricle is normal only, but there is lot of changes in the subendocardium there, and non-ischemic LV scarring is there, or isolated global or regional hypokinesia without dilatation, highly arrhythmogenic. This is prone for arrhythmias. And you have ARVC. This is the arrhythmogenic right ventricular type of hypertrophy. There is a right ventricular as well as arrhythmogenic posture. Predominantly right ventricular dilatation, dysfunction with fibrofatty infiltration. This is called the ARVC. Finally, the restrictive cardiomyopathy, also known as RCM, normal ventricular size, biatrial enlargement, severe diastolic dysfunction. Needless to say that this presentation is the game-changing one, and it is the state-of-the-art presentation on cardiomyopathies. You will have to find several guidelines to understand this presentation. I am giving you in a very nutshell HCM, DCM, NDLVC, ARVC, and RCM. NDLVC is a new entity, non-dilated left ventricular cardiomyopathy. Now, the 5 main phenotypes: HCM, hypertrophic cardiomyopathy, morphologically hypertrophy, 0.2% of the people have this. DCM, dilated cardiomyopathy, dilatation and systolic dysfunction is the hallmark. So this is the prevalence here. NDLVC, non-dilated left ventricular hypertrophy with global or regional dysfunction, prevalence not yet determined. ARVC, arrhythmogenic right ventricular hypertrophy. Here right ventricle and left ventricle fibrofatty replacement can occur and lot of arrhythmias are possible here. The prevalence is also quite high. RCM, restrictive cardiomyopathy. Morphology, normal dimensions, severe diastolic dysfunction. Restrictive cardiomyopathy is characterized by diastolic dysfunction, quite very rare. This must be functionally and structurally differentiated from constrictive pericarditis. Now, the triad of modern cardiomyopathy management. One is the phenotyping, structural imaging, and identify to which phenotype of the 5 the patient belongs. 2, get the genetic profiling and the genotype. Then you have a definite diagnosis, a multidisciplinary cascade Multidisciplinary cascade and proband case identification will be required. That leads to targeted intervention therapy and threshold-driven GDMT, guideline directed medical therapy. GDMT is guideline directed medical therapy. SRS, septal reduction surgery, and invasive therapies like ICD, and then this ERT. So these are the modern managements. The triad of modern cardiomyopathy management guidelines now universally mandate the integration of high-resolution phenotype, genotypic confirmation, and targeted intervention. Single-axis diagnosis is obsolete. What is single-axis diagnosis? Previous day we used to call restrictive, obstructive, like that. That is a single-axis diagnosis. Here it is a multimodal approach, that is the structural imaging, genetic profiling, and GDMT, guideline directed medical therapy. Okay, cardiomyopathy mindset has to change. What is the mindset? First one is ventricular morphology and ventricular function. What is the ventricular morphology? What is the ventricular function? Is it hypertrophic? Is it dilated? Is it non-dilated LVC? Is it arrhythmogenic? Is it restrictive? All the 5 types you have to keep in. This is the morphological and functional classification. Then you have the genetic architecture, family history, inheritance patterns, and sequencing. From the proband case, you have to see. Proband case means the index case. The case which has come for diagnosis is called the proband case. Additional tests, ECG anomalies, lab biomarkers, extracardiac physical symptoms. Always, in every patient of cardiomyopathy, you must look for extracardiac signs and symptoms. All these things integrated is the etiological diagnosis. The clinical part here, the ESC nomenclature prompts clinicians to consider myopathy as the cause of several clinical presentations, focusing simultaneously on myocardial structure and external syndromic clues. There will be myocardial structural abnormalities and functional abnormalities. There will be non-myocardial, extramyocardial, external syndromic clues will be there. Together is the diagnosis. Clinical red flags and symptoms, where I have to be very careful, where I have to watch for problems. This is called red flags. Learning difficulties in the patient, developmental delay, mitochondrial disease, Nonance syndrome, Danon's disease. This could be short notes, Nonance syndrome or Danon's disease. These are, a child will have learning difficulty, usually seen in children, mitochondrial disease. Second one, sensorineural deafness. So mitochondrial disease. Sensorineural deafness means patient has got a myocardial disease along with the cardiomyopathy. And the patient has got muscle weakness, muscle atrophy, suspicion, dystrophinopathies, and myotonic dystrophy. So what I am looking for now? Learning difficulties, developmental delays, sensorineural disease, muscle weakness, and atrophy. Summary, non-cardiac symptoms act as crucial pointers. General physical examination provides immediate diagnostic clues in symptomatic and metabolic cardiomyopathies. Don't think the cardiomyopathy is a disease only pertaining to the heart. There are what are called the metabolic cardiomyopathy. Now, the phenotype-based integrated diagnostic workflow. What I will do? Phenotype-based integrated workflow. The first one is clinical suspicion, symptoms, ECG abnormalities, family history. That should lead to the phenotypic identification. First, clinical suspicion of cardiomyopathy. Second level is the phenotypic identification. Multimodality imaging, echo, cardiac muscle, cardiac MRI are to classify into one of the big 5 classes. Obstructive cardiomyopathy, dilated cardiomyopathy, non-dilated left ventricular cardiomyopathy, arrhythmogenic ventricular cardiomyopathy, and restrictive cardiomyopathy. Phase 3, rule out phenocopies. That is, assess abnormal loading conditions, severe hypertension, or coronary artery disease. These are not cardiomyopathies, but appear as though cardiomyopathy. Why? In severe hypertension, in coronary artery disease, there will be left ventricular hypertrophy, which will mimic the cardiomyopathy. These are called the phenocopies. Exclude them. And finally, make an etiological diagnosis based on genetic testing, systemic labs, endomyocardial biopsy, and systemic clues. The clinical part, identifying the structural phenotype, is only one step. Saying it is dilated or restrictive or hypertrophic is only a part of your job. The ultimate goal is to specify the etiology, like sarcomeric mutation or amyloidosis. Is there an identifiable etiology underlying? Now, physical examination, baseline ECG. Look for heart failure signs, tachypnea, poor feeding in infants, fatigue, dyspnea, palpitation in adults. Structural clues, murmurs associated with left ventricular outflow tract obstruction. Like, aortic stenosis, what murmur you get. Similarly, left ventricular outflow tract obstruction. LVOTO. LVOTO is left ventricular outflow tract obstruction. That is the classical terminology today. LVOTO is left ventricular outflow tract obstruction. Baseline ECG must be obtained. Standard ECG abnormalities like left ventricular hypertrophy are common in all the subtypes and can precede the development of overt morphological phenotyping many years. That means ECG abnormalities run some 10 to 15 years before actually the cardiomyopathy develops. Clues, voltage criteria, pseudo Q waves, conduction delays must be cross-referenced with the age and inheritance patterns. Never ignore voltage criteria and pseudo Q waves and then the conduction delays. They could be a hallmark of future cardiomyopathy. Now, what laboratory screening I do? Whenever I show the green-blue, that is high-level evidence. Second one is the orange color is a second-level evidence. First-level tests are 1C evidence recommended in all patients with suspected or confirmed cardiomyopathy to evaluate the etiology, assess the severity, and detect the secondary organ dysfunction. This includes CBC, renal function, liver function, and creatinine kinase. Okay, Tier 2 tests. What are the Tier 2 tests? Should be considered in patients with extracardiac features to aid in the detection of metabolic or syndromic causes following specialist evaluation. The routine first level are recommended in all patients. These are CBC, renal function, liver function, creatinine kinase, apart from echo, cardiac MRI, and ECG. And special second level additional tests are required in those patients who have either a metabolic cardiomyopathy or who are having syndromic multisystem involvement features. Now, multimodality imaging overview. MDI, multimodality imaging. What is the baseline? You see the base of the pyramid. Echocardiography is the base of the pyramid, and routine, functional, accessible, and structural foundation. This is a routine test, a functional test, a structural test, highly accessible, and this is the structural foundation for our diagnosis. Second one is called CMR. We don't write MRI here. It just says CMR. CMR means cardiac magnetic resonance. Tissue characterization, any scarring is there, mapping the scarring and disease progression, highly useful for prognosis also. Advanced nuclear and CT tests. So, highly specific molecular and metabolic targeting bone tracers scintigraphy for the advanced features of the cardiomyopathy. Multimodality imaging characterizes the phenotype, identifies the abnormal morphology and function, and detects non-ischemic scar or fatty replacement. Supposing there is a scar in the myocardium, it could be due to previous ischemia and a scar has formed. There is hypokinesia in the ECG. There is scar in the MRI. But if it is a non-ischemic scar formation or non-ischemic amyloid or fatty deposition, that can be picked up by cardiac MRI and very important. Next one, echocardiography, class 1 roles. As you see here, this is the left atrium, it's the left ventricular outflow. Left ventricular outflow is obstructed, so much of some amount of regurgitation into the left atrium. ESC mandate a comprehensive evaluation of cardiac dimensions. All the chamber dimensions, both systolic and diastolic, must be obtained. LV and RV systolic, global and regional, LV diastolic function is essential to be documented at the initial evaluation and of course during follow-up. Level of evidence 1B. Now, crucial diagnostic role, multimodality imaging MDI must be used to differentiate restrictive cardiomyopathy from obstructive cardiomyopathy or dilated cardiomyopathy with restrictive physiology. So in this, you require a 4-chamber view also like that, and this will be the second useful utility of echocardiography. Now, CMR. What is CMR? Cardiac MRI. Cardiac MRI, you see, initial evaluation, capabilities independent of acoustic window. CMR does not depend on the acoustic window. Fatty man, obese woman, acoustic window is poor, echocardiography may not be very clearly demonstrating. But CMR is independent of the acoustic window. Unmatched tissue characterization routinely include cine, T2 weighted, pre-post contrast T1, ECV, and T2 mapping specific for hemochromatosis. Metabolic cardiomyopathy, hemochromatosis is one type. Indications, serial follow for every 2 to 5 years to monitor the disease progression, risk stratification, therapeutic response, particularly in Anderson-Fabry or cardiac amyloidosis in those conditions. Level 2A, level C, 2A. Now, most important thing is LGE. What is LGE? Late gadolinium enhancement. What did I do now? First, we did the routine echocardiography with measurements of all the chambers, pressures, and also the gradients. Second step is to do a cardiac MRI to look for scar tissue other than the ischemic scar, and also to look for fatty infiltration, amyloid infiltration, hemochromatosis infiltration, etc. Now, the third important imaging modality is late gadolinium enhancement, also called the LGE. CMR and LGE. Remember here, you see subendothelial, subendocardial, HCM, DCM, NDLVC, ARVC, RCM. None of them have any subendocardial lesions. The clinical pearl is the disease is not subendocardial or endocardial. The disease is in the midwall or epicardial, spares the endocardium and the subendocardium. Midwall, HCM and DCM is the part that is involved in the middle of the muscular wall of the ventricle. Patchy LGE at RV insertion point or maximum hypertrophy. Epicardial, particularly when the erythmogenic type, fibrofatty replacement, often visible in the right ventricular epicardial free wall. Supposing it is not discriminating midwall and epicardial and it is diffuse, it is like amyloidosis, diffuse subendocardial or transmural LGE. This is a restrictive type of cardiomyopathy. So you have to understand late gadolinium enhancement is the latest modality of understanding and evaluating cardiomyopathy. Now, advanced imaging, nuclear imaging, and ATTR. Okay, nuclear imaging, computer tomography you first do, CT of the cardiac CT, primarily utilized for coronary evaluation. Why I do CT? To see how the coronaries are, whether it is ischemic cardiomyopathy. I wanted to rule. Okay, ischemic causes or when CMR is not possible, then you do a CT. Okay. Why CMR is not possible? Whenever there is some magnetic implant, some metal implants in the body, somebody is wearing a pacemaker, then you cannot do a CMR. Then you have to do a cardiac CT. That's called CT of the heart. Then clinic nuclear imaging, scintigraphy, and indications are DPD, PYP, HDMP, bone tracer scintigraphy. So several types of molecules are there which can be used as tracers. ESC mandate recommended in patients with suspected ATTR-related cardiac amyloidosis to aid the diagnosis. This is the nuclear imaging. Now, at the end of the presentation, I am going to share one PDF which will give you the expansion of all the abbreviations used in the ESC and AHA guidelines. So it's important because these are new terms and they write ATTR, DPD. What does that mean? You should know. For that there is a reckoner for you. I'm going to give you that PDF straight away. Now, what is the fifth level of investigation? First, echocardiography. Second, cardiac MRI. After the cardiac MRI, what did we look at? Cardiac MRI, then we gadolinium enhancement, LGE, then we looked at the cardiac CT, then nuclear imaging, and finally, endomyocardial biopsy. Endomyocardial biopsy should be considered in patients with restrictive cardiomyopathy to exclude specific diagnosis. EMB is not a routine procedure. EMB is not required in all cardiomyopathies. It is required in those patients suggestive of restrictive cardiomyopathy, particularly to exclude other conditions like hemochromatosis, other storage disorders, mitochondrial cytopathies, amyloidosis, granulomatous myocardial disease, restrictive myocardial disease, Desmin variants. For that, the level of evidence is 2C. Endomyocardial biopsy should be considered. Now, I'm just summarizing what are all the various investigations required for that. So first and foremost will be echocardiography. Second will be the CMR, cardiac MR, and then the advanced nuclear and CT tests. Now, first one, echo is required to classify the disease. Phenotypically, to classify the disease, you require the echocardiography, 2D echocardiography with all chamber measurements and chamber gradients and also flow measurement, and also the wall thickness should also be done. Then you do the CMR, very important for your evaluation, particularly T2 weighted images, pre and post contrast, and then the mapping. This is very important for follow-up and tracking. The third important investigation is the gadolinium enhancement. LGE is called late gadolinium enhancement. As I told you, subendocardial lesions are not there at all in my cardiomyopathy. It is the myocardium, midwall, or epicardium, or diffuse disease. Never it involves endocardium or subendocardium. Now, fine. Then you have the cardiac CT. In case where you cannot do an MRI and you want to evaluate the coronaries, you have to do a cardiac CT. Nuclear imaging is essential for ATTR-related cardiac amyloidosis and diagnosis. And finally, endomyocardial biopsy. Endomyocardial biopsy is not a routine procedure. It is essential in cases of restrictive cardiomyopathy, RCM, and it is very important to exclude specific diagnoses, particularly hemochromatosis, iron overload, storage disorders, myocardial cytopathies, amyloidosis, granulomatous myocardial disease, restrictive myofibrillar disease, also called the Desmin variant. Now, this is all about the investigations. Now, we have to do the genetic architecture also. I told you there are three things: physical examination and evaluation, symptomatology, genetic architecture, and syndromes. Those who are associated with non-cardiac symptoms. Autosomal dominant, dynamics, 50% transmission risk, most common pattern for sarcomeric HCM and DCM. HCM is hypertrophic cardiomyopathy, DCM is dilated cardiomyopathy. It is usually autosomal dominant. Autosomal recessive, dynamic, 25% risk if both parents carry the gene, offending gene, often associated with severe early onset syndromic phenotype. So if a patient has got early onset cardiomyopathy and has got syndromic phenotypes, most likely it is autosomal recessive. And there is a 25% risk if both the parents are the carriers. Autosomal dominant, usually HCM and DCM, and 50% risk of the offsprings developing. X-linked cardiomyopathies, dynamic, males predominantly severely affected. X-linked ones, we see majority only in the males. Clinical clue, Dannon's disease, dystrophinopathies are X-linked. There is what is called the matrilineal inheritance. What is matrilineal inheritance? You not only have the chromosomes in the nucleus, there is nuclear material in the cytoplasm also. This is exclusively maternal. It is the nuclear material of the cytoplasm is not transmitted from the father. The nuclear material in the cell is transmitted from both the parents. The nuclear material which is in the mitochondria, the DNA material in the mitochondria, which is there in the mother, it is there in the mother's cell. It did not come from the father's cell. This is called the maternal transmission only. Mitochondrial diseases often linked to sensory neural deafness and learning delays is matrilineal transmission. Now you have to understand, earlier we were studying autosomal dominant, autosomal recessive, X-linked. Now there is another variety of transmission called the mitochondrial transmission from the mother to the children, matrilineal transmission. This also is possible. Now, what are the genetic architectures of cardiomyopathy? The sarcomere may be affected, desmosomes may be affected, cytoskeleton of the muscle cell may be affected. If the sarcomeres are affected, these are the MYBPC3, MYH7 abnormality. Desmosomes, DSP and PKP2. Cytoskeleton, CMNA and FLNC. I told you I'll give you a PDF which will give you abbreviations, expansions of all the abbreviations. Now, sarcomere type, classical HCM. Desmosome type, classical AVRC. Cytoskeleton type, classical DCM and LVD. And there will be combinations also. A genotype test positive result fundamentally transforms patient's prognostication and reproductive planning. Now, what do you understand by this? A patient has come, he has cardiomyopathy, he does not have any genotypic abnormality, only phenotypic problem is there. Then the risk of reproductive planning is not required and prognosis is usually good. And these people have come with symptoms only late in life. Whereas if the genotypic positive type of cardiomyopathy is there, fundamentally your thinking is changed now. Because the prognosis is poor, these patients start suffering early, and you need a reproductive planning for the index case because there is a chance of it transmitting into the next generation. If it is autosomal dominant, 50%, autosomal recessive, 25%, X-linked, the males will be affected, matrilineal, from the mother alone it comes. Genetic testing as a class 1 recommendation for index patients where it enables diagnosis, prognostication, therapeutic stratification, and cascade screening. This is a class 1 recommendation. For every index case, now the class 1 recommendation is you must explore the genetic side also. Genetic testing must be done for all the index patients. For what for? To enable the diagnosis, to prognosticate the patient, give the therapeutic stratification or cascade screening. What is cascade screening? I have an index case and screen above one generation, two generations above and one generation below. This is called the cascade genetic screening. I told you this presentation is not off the cuff. It is the state-of-the-art presentation on cardiomyopathies. If you know this, This is the latest 2024 and 2025 guidelines of European Society of Cardiology and American Heart Association are completely brought into this presentation. Genetic testing indications and result interpretations. ESC mandate, European Society of Cardiology mandate, genetic testing should be performed in patients with cardiomyopathy and may influence risk stratification and management. Class 1 recommendation. There are three possibilities can come. One, pathogenic, likely pathogenic. That is actionable. You can take action, confirms the etiology, unlocks the cascade screening for the family. That is green. The second one is UVS. What is UVS? Variant of uncertain significance. That is ambiguous. We cannot say it is genetic or we cannot say it is not genetic. Requires deep multidisciplinary team. MDT is the watchword in the treatment of management of cardiomyopathies. Multidisciplinary team approach is the catchword and the watchword. Clinical correlation has to be done. Do not use predictive family screening alone. Here, you have to clinically correlate and also use the family screening. Not family screening alone. This is for the variant of uncertain significance, UVS. Now, benign and likely benign mutations that you see, non-actionable, you don't have to do anything. Reevaluate your clinical phenotype and continue the treatment. You have no business to do any cascade screening in that. Okay. Now, cascade screening and family care. The catalyst, a multi-generation, 3 to 4 generations family tree must be created for all suspected patients, level 1, level C, class 1. What is that? This is the proband case, first degree relative, second degree relatives, third degree relatives. Not higher generations. First degree relative is brother, second degree relative is cousin, third degree relative is a distant person. And also parents and grandparents also. They become, the parents will be first degree relatives, grandparents will be second degree relatives. Like that, you have to do from the proband case, you extend the cascade screening to the first degree, second degree, third degree relatives. The following cascade genetic testing, clinical evaluation. First of all, what do you do for them? You do an ECG and cardiac imaging for the relative, and it is recommended. Then the first degree variants who share disease causing variant, you have to also look for them. Ultimate standard, multidisciplinary cardiomyopathy team, MDT, integration of cardiology, genetics, nursing, counseling to translate precise molecular diagnosis into holistic family survival. Today, we are not making any anatomical and functional diagnosis alone. We are making a molecular diagnosis also. Days have changed. Differential diagnostic matrix, HCM versus phenocopies. What are phenocopies? Those which look like cardiomyopathies and are not cardiomyopathies. Sarcomeric HCM, autosomal dominant inheritance, estimated 1 in 500 prevalence, distinct from secondary and syndromic causes. Metabolic and multi-organ syndromes, glycogen, lysosomal storage disease, Dannon's disease, key indicator, systemic multi-organ involvement will be there. RASopathies, that is Noonan syndrome, syndromic facial and developmental features will be there. Infiltrative and inflammatory, cardiac amyloidosis, sarcoidosis, voltage discordance, distinct MRI enhancement patterns. Secondary causes, athlete's heart, uncontrolled hypertension, valvular subvalvular stenosis, reversible upon offloading and deconditioning. Secondary causes are easily treatable. Now, phenotype-specific management and special scenarios. Again, 2023 European Society Cardiology and 2024 AHA-ACC, American Heart Association, American College of Cardiology guideline updates are utilized here. What are the 5 types? Hypertrophy, cardiomyopathy, dilated cardiomyopathy, non-dilated left ventricular cardiomyopathy, NDLVC, the new entity, ARVC, arrhythmogenic ventricular cardiomyopathy, and restrictive cardiomyopathy, RC. Each one we will deal one by one. Let us start with now there is another important thing is sudden cardiac death, arrhythmias and heart failure are 3 important complications associated with cardiomyopathy. SCD, sudden cardiac death driven by arrhythmic substrate and dynamic obstruction. Patient will sleep and tomorrow morning is not there, sudden cardiac death. Or exaggerated by left ventricular enlargement, LAE, and elevating filling pressures, atrial fibrillation. Progression from diastolic dysfunction to advanced heart failure, left ventricular ejection fraction less than 50% heart failure. So beware of the complications. Sudden cardiac death, atrial fibrillation, other arrhythmias, and cardiac failure. The diagnostic thresholds: unexplained left ventricular hypertrophy. Don't neglect unexplained left ventricular hypertrophy. What do you mean by unexplained? There is no hypertension as a cause for LVH, no ischemia as a cause for LVH, no aortic stenosis as a cause for LVH, no aortic regurgitation as a cause for LVH. There are so many secondary causes for left ventricular hypertrophy. If you don't have any one of the causes, and a patient has got left ventricular hypertrophy per se, such is called unexplained left ventricular hypertrophy. Be watchful. It could be cardiomyopathy. Then obstruction. Peak LVOTO. That is left ventricular outflow tract gradient. What is the gradient? Left ventricular pressure, aortic pressure. The pressure in the aorta, pressure in the left ventricle should almost be the same. If there is no obstruction, you see the left ventricular pressure, let's say 120, aortic pressure also 120, left ventricular pressure 150, aortic pressure 120. The gradient should not, if it is more than 30, it indicates obstruction. More than 50 establishes the need for advanced pharmacological treatment or SRS. SRS is septal reduction therapy. So, what is the LVOT gradient? I wanted to know whether it is less than 30, fine. 30, more than 30, obstruction. More than 50, treatment is essential, surgical may be required. Okay. Now, pathophysiology, unpacking the dynamic LVOT obstruction. You see, this is the mitral valve there, this is the septum, this is the left ventricle, whole left ventricle is hypertrophied. The septal hypertrophy is more dangerous because septum projects into the left ventricular outflow tract. That is, left ventricle to the aorta is called the outflow tract. There, the septum is bulging and narrowing. It produces a LVOT, left ventricular outflow tract obstruction. Yeah, okay. And also there is what is called the SAM. What is SAM? Systolic anterior movement. So whenever the ventricle contracts, the anterior leaflet of the mitral valve moves and goes towards this side, anteriorly. So much, the aorta is anterior. So much so, the aortic outlet is anterior. So much so, what will happen? When the valve moves this side, it narrows the outflow. So that is what is called the Venturi effect. Now, what is the reason for LVOT? Left ventricular outflow tract obstruction. 1, the septal hypertrophy and general left ventricular hypertrophy. 2, the systolic anterior valve, anterior motion of the mitral leaflet, and that is called SAM. So, LVOT is primarily caused by basal septal hypertrophy and SAM of the mitral valve. Secondary mitral regurgitation directly results from SAM, disrupting the leaflet coaptation. Coaptation means joining. If the 2 leaflets properly join, then there won't be any leak. Because the leaflet is moving anteriorly, there will be a chance for leak. That produces secondary mitral regurgitation. Dynamic sensitivity. This is very important. Obstruction is highly sensitive to ventricular preload. Suppose the ventricular preload I increase, then the obstruction becomes more. Afterload, that is resistant, and contractility, squeeze. There are three things. The preload is the amount of blood that is presented into the ventricle before it contracts is called the preload. Afterload, the amount of resistance the ventricle has to overcome when it is pumping is called the after. And the third one is the contractile force of the muscle itself, which is the squeeze. Volume, resistance, and squeeze. Preload, afterload, and contractility all have got a bearing on the LVOT, left ventricular outflow tract obstruction. This is the dynamics of LVOT. Now, obstructive HCM, what is the pharmacotherapy? There is a ladder pattern, step pattern. First line treatment is rate control, class 1. Beta blockers must be given titrated to the maximum tolerated dose. Which beta blocker? Metoprolol, carvedilol, nebivolol, bisoprolol. The newer generation beta blockers without intrinsic sympathomimetic activity. The alternatives are the beta blockers, contraindicated beta blockers, not tolerated. You are at liberty to give verapamil and diltiazem. Verapamil or diltiazem, not CCBs. Okay, verapamil and diltiazem are also calcium channel blockers, not the regular dihydropyrimidine type of calcium channel blockers like amlodipine. So first drug of choice, newer generation beta blocker, alternative drug of choice, verapamil and diltiazem. And you should titrate the dose to the maximum to keep the LVOT gradient less than that. Then add on antiarrhythmic agents. Class 1 level B, disopyramide is the drug of choice, 400 to 600 milligrams. Red flag, requires QTC monitoring because it can cause QT prolongation. Monitor for anticholinergic effect because disopyramidine will have anticholinergic side effects like dryness of the mouth, constipation, inability to void urine. These are the anticholinergic side effects. You should monitor that. Type 3 is advanced targeted therapy, ATT. ATT is advanced targeted therapy. Transition to cardiac myosin inhibitors. There is a specific drug called cardiac myosin inhibitor, mavacetam. Mavacamten. Mavacamten is the drug of choice before considering invasive procedure. What is the medical management of obstructive cardiomyopathy? First line, rate control, beta blockers, new generation beta blockers, nebivolol, bisoprolol, carvedilol, metoprolol. Alternative, verapamil, diltiazem. Second step, if not controlled with that, add antiarrhythmic drug, disopyramide. Beware of the anticholinergic side effect and look for the QT interval. Then targeted therapy with cardiac myosin inhibitor, CMIs. These are called the cardiac myosin inhibitors. Mavacamten. Mavacamten is the new drug that can be used. This is before surgery. This is the breakthrough therapy, cardiac myosin inhibitor. How does it act? You see the hypercontractile sarcomere here. Normally what is happening? There is ATPase is there. This ATPase cleaves the ATP into ADP and produces phosphate that triggers the hypercontractility of the sarcomere. Now we interfere with that ATPase and inhibit the myosin ATPase. That myosin ATPase inhibitor is the newer drug mavacamten. This mavacamten reduces the energy load. There, ATPase inhibitor, there is less energy for the muscle to get hypertrophied and then it relaxes. This is called, this is important in myocardial energetics. In myocardial energy dissipation, energy distribution. A breakthrough treatment, myosin inhibitor, also called the mavacamten. Clinical evidence, explorer trial, Explorer HCM trial, symptomatic obstructive HCM, NYH class 2 to 3, ejection fraction more than 55. Who are the candidates? They must have symptomatic obstruction, never treat with inhibitors. Somebody is asymptomatic simply because echo has shown some obstruction. They must be symptomatic obstructive HCM, at least of class 2 to class 3 NYH, and still the ejection fraction is more than 55. Outcome, 25% achieved LVOT gradient less than 30. Improved to NYH class 1 from class 2 and class 3. Recommendation, class 1 recommendation, titrate to maximum tolerated dose of mavacamten and until the symptomatic improvement. Safety, transient LV systolic dysfunction may be observed, but it will resolve on continuation. So, summarizing the HCM, the first one, I told you sudden cardiac death, atrial fibrillation, heart failure should be remembered, unexplained left ventricular hypertrophy should not be ignored, obstruction to the peak flow gradient more than 30 millimeters is already obstruction, more than 50 severe obstruction, needing pharmacological treatment and septal resection. So, you have to understand left ventricular dynamics and also the step care therapy and treatment. First line, second line, and first line beta blockers, verapamil, diltiazem. Second line, antiarrhythmic drugs like disopyramidine. And finally, targeted cardiac myosin inhibitor, mavacamten. When you use mavacamten, what is the role, how it works, I have shown you here. Now, SRS. In refractory cases, you do what are called the SRT, which is called the septal reduction treatment. So, decision algorithm, when I submit the patient for septal resection, primary indication, LVOT gradient more than 50, NYH class 3 and 4, despite maximum tolerated medical therapy. You see, we are talking about hypertrophic cardiomyopathy, surgical myomectomy, intrinsic mitral valve disease, markedly elongated anterior leaflet, anomalous papillary muscle, children and young adults. Rule out, mitral valve replacement should not be performed solely to relieve LVOT. Simply because there is a LVOT, you should not do the procedure. There must be symptomatic NYH 3 or 4 and pressure gradient should be more than 50. Despite maximal medical treatment, patient has not improved, then only surgery will be considered. Or we have got ASA, alcohol septal ablation, advanced age, high surgical risk, contraindications to surgery. When the surgery is contraindicated, elderly fellow, surgical risk is very high, but he is symptomatic, maximum medical treatment is used, then I switch on to ASA, alcohol septal ablation. What happens with alcohol injected into the septum? It makes it fibrosed and then the septal thickness will regress. Also, it will produce there is a conducting bundle there in the septum and that AV block will occur. That might require a pacemaker in about 7 to 20%. That means he will get into either LBB or RBB or total bundle branch block might occur. AV block can occur. You have to treat with the pacemaker because no longer the conduction bundle is working because of your alcohol ablation. Now, MDT. MDT is multidisciplinary team. SRT must be performed by experienced multidisciplinary teams only. The multidisciplinary team cardiologist, the surgeon, and the genetist, and the nurse practitioner, everyone is involved there. Okay. Now, the second one is DCM. Now, we have changed from the red there, HCM. See, look at the icon there. The second one is DCM. That is the blue we have put. Mechanism to management matrix. Dilated cardiomyopathy. Genetics are imperative. Whereas in HCM, genetics may not be required. Unexplained left ventricular or biventricular dilatation, depressed myocardial systolic function in the absence of abnormal loading conditions. What are abnormal loading conditions? Hypertension, ischemic heart disease, aortic stenosis, aortic regurgitation. Any of those abnormal loading conditions are not there. There is no coronary artery disease, but then there is a ventricular dilatation. Normally, we see ventricular dilatation. And so many causes are there for ventricular dilatation. In the absence of abnormal conditions which produce a secondary dilatation of the ventricle, if a patient de novo has got decreased myocardial systolic function and left ventricular or biventricular dilatation, that is a case of DCM. Management and high-risk genotypes. Genetic testing identifies at-risk family members, guided therapy, prevents unnecessary serial follow-ups. Prioritization tool, utilize the Madrid DCM genotype score to identify high probability positive genotypes with resources are limited. That means you don't have to do the genotyping from everyone. You do the Madrid DCM genotyping score. Just type that, you will know what is Madrid DCM genotype score. And if the score has got crossed a certain level, then only you do the genotype testing. Otherwise, it is not ready. Clinical rule, age should not be a limiting factor in deciding genetic testing eligibility for DC. Suppose somebody is very elderly. No, why elderly fellow, why genetic testing? It may be second, it may not be real. No, not like that. Younger old, that is not a clinical diagnostic yardstick to do a genetic testing. Now, the third entity is NDLVC. This is a new entity. That is non-dilated left ventricular cardiomyopathy, NDLVC. We have given the green code for that. Diagnostic hallmarks, left ventricular systolic dysfunction without dilatation. You see, a condition where whenever you have a systolic dysfunction, you obviously have either a hypertrophy or dilatation. Here there is no hypertrophy, there is no dilatation, but the ventricle is not contracting. Why? Why it is not contracting? Because it is fibrous. It is deposited with material. So normally when the ventricular dysfunction is because of hypertrophy, not able to meet with the proper contraction, and blood supply also is demand supply ratio is also skewed because of hypertrophy. Or if the ventricle is dilated, then we are not able to compress properly and then send the blood out. Here there is no dilatation, there is no hypertrophy, but still it is not contracting. Why? Ventricular dysfunction without any prior or salient infarct. Presence of non-ischemic structural myocardial abnormality. These myocardial abnormalities are non-ischemic. Scarring and fibrosis. There is scarring of the muscle, ventricular muscle, without there being an ischemic reason, and fibrosis. Presence of non-ischemic structural myocardial scarring or fibrosis. What do you have to do? Cardiac MRI. CMR is mandatory because that is the only modality which picks up the NDLVC and the scarring and fibrosis. This is to differentiate early DCM or prior salient infarcts. Late gadolinium enhancement is a definitive biomarker. You don't do gadolinium enhancement for everyone. First do a CMR and have a suspicion that there is a structural myocardial abnormality like scarring or fibrosis. To confirm that, you do a LGE. What is LGE? Late gadolinium enhancement. Definitive biomarker. The distribution and burden of late gadolinium enhancement fundamentally drive the primary prevention strategy for sudden cardiac death. So, if you want to prevent sudden cardiac death in NDLVC, you must do CMR and LGE and identify that there is scarring and fibrosis, and these are prone for arrhythmias. Extensive myocardial scar signals a markedly increased risk for ventricular tachyarrhythmias, particularly ventricular tachycardia, dictating ICD timing. If you do a LGE and find there is scarring, he is a candidate for SCD, sudden cardiac death. You must overcome that by preventing malignant arrhythmia. You have to decide in favor of ICD, that is implantable devices, implantable cardiac devices you have to use. The fourth type is called arrhythmogenic right ventricular hypertrophy. So this is the ERVC. Though we say right ventricular, it could be left ventricular also. Diagnostic hallmarks: progressive fibrofatty replacement of the right ventricular myocardium. Mainly the target here is the right ventricle. High risk of life-threatening ventricular arrhythmias, often preceding structural changes. Targeted antiarrhythmic management: here pharmacotherapy is the pillar. In the earlier one, the implanted devices are the pillar. In the previous one, using the myosin inhibitors. Now here, pharmacotherapy for beta blockers are the cornerstone in reducing the arrhythmic burden. AAD, that is antiarrhythmic drugs, escalation, integration of specific antiarrhythmic drugs when beta blockers are not sufficient. Desmopirid can be used. Environmental triggers. Intense exercise accelerates phenotypic progression and SCD risk. So, strict limitation of physical activity and competitive sports is mandatory in ARVC. He should not exert beyond normal routine. No competitive sports, no running, no frequent climbing multi-level stairs, no physical exertion, because there is a right ventricular hypertrophy which is arrhythmogenic. It can produce sudden cardiac death. So this is a very behavioral modification. And finally, you have the restrictive cardiomyopathy or the RCM. So clinical red flags: RCM profile, severe diastolic dysfunction. Why? Heart is not able to relax at all. Diastolic dysfunction is the presenting feature. Restrictive pill filling fashion. Preserved or near preserved systolic function. They will have diastolic dysfunction, diastolic heart failure. Every patient with diastolic heart failure, you must evaluate for RCM, though it is rare. Preserved or nearly preserved systolic function, massive biatrial enlargement because the ventricles are not properly contracting. There is pooling of the blood, and biatrial enlargement, left and right atria are enlarged with normal or reduced ventricular volumes. If you look at the ventricular volume, they are shrunken. Atrial volumes, bigger. Diagnostic dilemma: is it constrictive pericarditis? I wanted to know. Is it constrictive pericarditis? RCM versus constrictive pericarditis. Distinguishing the two is critical because constriction is surgically curable. Suppose it's constrictive pericarditis, I can open the pericardium and you do pericardiectomy, I can do. It is surgically curable. While restrictive cardiomyopathy requires a cardiac transplant. It's very imperative to differentiate restrictive cardiomyopathy from constrictive pericarditis. What is constrictive pericarditis? Maybe tubercular, maybe other infections which have affected the pericardium. There is pericardial inflammation. The inflammation and infection has led to adhesion, and that led to like a very rigid pericardium around the heart, like a sleeve, and then it's not able to expand. Treatment is surgical resection of the pericardium. Whereas restrictive cardiomyopathy requires multimodality imaging, echo, cardiac, MRI, detect pericardial thickening and inflammation, constriction versus diffuse myocardial inflammation, which is called the RC. How to differentiate? Echo and cardiac MRI to detect and differentiate between restrictive cardiomyopathy and constrictive pericarditis. Why I need to distinguish? The treatment is entirely different. Okay. Now, RCM management and hemodynamics and advanced therapy. How do I manage RCM? Aggressive volume management, hemodynamic profiling, and cardiac transplant window. Cautious but persistent diuresis to manage the profound venous congestion, to reduce the size of the dilated atria. Challenge: balancing the lower filling pressures without compromising the cardiac output due to stiff preload dependent ventricle. Ventricle is dependent only on the preload, and if you cut the preload, then what will happen? Naturally, the cardiac output will be reduced. But if you keep the preload more, then there will be heart failure. That is the balance. Routine pulmonary vascular resistance measurement. This is called the pulmonary wedge pressure, PVR. You have to see pulmonary vascular resistance measurement, crucial for ruling out irreversible and fixed pulmonary hypertension. So you have to rule out fixed pulmonary hypertension and irreversible pulmonary hypertension before you go forward. Then the transplant window, early proactive evaluation for cardiac transplantation is mandatory. Clinical deterioration is rapid and unpredictable. So you have to be very proactive and look for the chance to give cardiac transplantation as an option as early as possible. You cannot wait because the progression will be very fast and unpredictable. Establish the eligibility before secondary organ failure. That is why the transplant window is rather very, very small in this particular case. The window for offering a transplant is very small. This is about the restrictive cardiomyopathy. Now, you have the sudden cardiac death. What is sudden cardiac death? Validated risk stratification for sudden cardiac death. Core mandate is assess the sudden cardiac death risk at initial evaluation and every 1 year or 2 years. Must screen unexplained syncope, personal history of arrest, and sustained ventricular arrhythmias. ESC framework, American Heart Association framework. Tool, HCM risk SCD calculator is available on the website. Use the ESC framework, hypertrophic cardiomyopathy risk sudden SCD calculator. Type that, HCM risk SCD calculator. Feed the thing. Then you know the risk estimate for the sudden cardiac death. Variables in that scoring are age, maximum wall thickness, left atrial size, LVOT gradient, left ventricular outflow tract gradient, family history of sudden cardiac death, NVST, that is significant supraventricular arrhythmias and unexplained syncope. These are the variables put into the calculator. You get a risk estimate. The one important thing is you should prevent sudden cardiac death in cases of this cardiomyopathy. Pediatric specifics recommends calculating an estimated 5-year risk using echocardiographic parameters and genotype for children less than 16. Additional variables emphasizes the additive value of extensive late gadolinium enhancement LGE on CMR. Cardiac MRI and apical aneurysms is a holistic risk evaluation. So these are the differences between AHA, American Heart Association, American College of Cardiology guidelines, and the European Society of Cardiology guidelines. Now, ICD decision. When do I offer intracardiac devices? ICD consideration, primary and secondary. Primary prevention, we see calculated risk based on the continuous evaluation of 5-year SCD, extensive late gadolinium enhancement scanning, left ventricular ejection fraction decline, and a high-risk genetic profile. If somebody has got extensive LGE positivity and the SCD risk estimate is high and LVF is fast declining and the high-risk genetic profile is there, and this is a primary prevention, you have to offer ICD straight away, because to prevent your sudden cardiac attention. Now, shared decision making to weigh the lifetime risk of device complications against the absolute risk reduction for sudden cardiac death. Now, you have the secondary prevention. When do I do that? Absolute indication, class 1. Survivors of cardiac arrest, ventricular tachycardia, ventricular fibrillation, or patients with spontaneous sustained ventricular tachycardia causing hemodynamic compromise. Attention, immediate ICD must be recommended. So this is a device therapy. ICD is implantable cardiac devices. Now, we have got 1 or 2 more slides. We will close. Tailoring the modern treatment for cardiomyopathy. What is GDMT? Guideline directed medical treatment. How do I do that? Now, scenario is a transition to systolic dysfunction less than 50%. Rule out alternate etiologies, particularly coronary artery disease. GDMT per standard heart failure guidelines, regardless of the underlying primary cardiomyopathy phenotype. Scenario B, asymptomatic obstructive patient, septal reduction therapy should not be performed in asymptomatic. I told you earlier, if the patient is asymptomatic, don't offer SRT. Septal reduction therapy is only for the NYH class 3 or class 4. Below that, we should not offer. Medical stance, preventive medical therapy for purely asymptomatic carriers requires highly tailored clinical judgment, avoiding aggressive over-treatment. This is very important for the guideline-directed medical therapy. Now, there are a few more slides. Probably I will take up in the next class. Yeah, you require those things also. Maybe we will stop short here and then we will continue in the next lecture about the remaining parts. Okay. Now, students can exit from the